Next case will be case discussion on the rib fracture, and examiner will be Dr. Sandeep Diwan sir, and fellow will be Dr. Pooja Jadhav. Over to you Sandeep sir.
Good afternoon, everyone. I'm Dr. Pooja Jadhav. My moderator is Dr. Sandeep Divansar. I'm presenting the refracture
Timer,
case.
I'll request the tech team to start the timer. Yeah, so sorry. Thank you.
History of present illness. 40 years old male, resident of Pune, accountant by profession, presented in casualty with the history of road traffic accident. Injury. He had injury over right shoulder and right chest. No history of head injury. Past history is a known case of hypertension controlled on tablet amlodipine 5 milligram OD. No other known comorbidities. He no history of recent illness, surgery, or anesthesia exposure in past. No known allergy. Family history of this patient is not significant. Personal history: no addiction, sleep appetite normal, bowel bladder function normal, diet is mixed. On examination, a patient is afebrile, averagely built, weight is 65 kg, height is 168 cm, BMI is 20 kg per meter square, pulse 100 beats per minute, blood pressure 132 to 72 mm of Hg, respiratory rate 16 per minute, then abdominal thoracic breathing, shallow breathing, pain while breathing at rest and while coughing. The saturation was 92% on room air. Airway examination, mouth opening 3 fingers, Malampatti grade 2, no artificial dentures and no loose tooth. Spine examination, no deformity, a scar, itching, lesions over the thoracic and lumbar spine. On systemic examination, respiratory system, air entry decrease on the left side. In CVS, S1, S2 heard, no murmur. Per abdomen was soft and non-tender. CNS, patient was conscious oriented to time, place, person, and motor power 5 by 5 in all the 4 limbs. On local examination, bruising was seen over the left chest wall. Chest wall tenderness present over left side and no abrasions or open wound or no evidence of skin infection. Investigations, complete blood count, hemoglobin was 11, PT-INR, liver function test with enzymes, renal function test with serum electrolytes within normal limit, chest X-ray showed left third to sixth rib fracture, and X-ray shoulder AP view showed proximal humerus fracture, ECG normal sinus rhythm. So this patient diagnosis is 40 years male, hypertensive under control, diagnosed with left third to sixth rib fracture and proximal humerus fracture without any abdominal injury or other injuries.
So, Dr. Pooja, I just wanted to know this. Now, this patient is in intensive care unit, and you have been called for a pain intervention. So, how would you start the pain intervention?
So, for the algorithm in the literature, which has step 1, 2, 3, 4 given in the literature. So according to that, if patient is having, we have to see the pain score also. So first step, we will start with the simple analgesics, intravenous paracetamol, followed by if pain score are on the higher side, we can add NSAIDs also. If pain score on higher side, we can give intravenous fentanyl and followed by intravenous patient control analgesia. If still patient is having higher pain, with the help of this risk stratification score, if it is on higher side, we can intervene with the regional anesthesia techniques.
Now, what makes you feel that the patient would like to have interventional pain management in the form of regional anesthesia? That is one. And second thing, intravenous fentanyl infusions, you would start in the casualty itself, or you would like to shift the patient to intensive care unit, or what makes you feel that, or what sort of patients would you shift to intensive care unit?
Sir, for this patient, if we need a regional intervention, then I would like to shift this patient in the intensive care unit for further monitoring. If I'm using intravenous fentanyl, I have to monitor the saturation, the respiratory rate, and so I would like to shift this patient to the intensive care unit and then do the interventional regional anesthesia technique.
You said that you would like to do an interventional regional technique, but what would be the end point? Like now you have given a lot of these medications. He's not responding to NSAIDs, not responding to intravenous fentanyl infusion. So is this the point that you intervene with the with regional anesthesia, or is there anything else that would determine regional anesthesia?
Sir, for that, there are scores given in the literature, which is stumble score and the wrist fracture score. So, according to that score, if the score is more than 30, then I'll prefer, if for stumble score, if the score is more than 30, then I would prefer the regional anesthesia intervention. And according to the rib fracture score, if it is more than 15, I will prefer the regional intervention. So the scoring system includes
The rib fracture score more than,
more than 15.
so you're going to wait until 15, or it's less than that?
Sir, I have a slide for this score.
Yeah.
May I share it?
Yes, please do that. That is the first one. No, the green one. So this is the article which I think everybody should go through. This shows from not this one. Yeah, don't change. This is by Tim May and in British Journal Anesthesia 2016. You can see the algorithm where they have the step 1, 2, 3, and 4, and we routinely follow this in our institute as well. And you can see the rib fracture scores as well, which is the breaks into sites plus the age factor, and that's the age factor, and that's the score. So a score of more than 7. Did you get it, Dr. Pooja? The score of more than 7 requires referral to the acute pain team. Now, a couple of times, what happens is that we are asked to intervene prior to this, in spite of the rib fracture score not more than 7, and that is would be more ideal. If you go and look into the literature, they say more than 7, but less than 7 also you can intervene, and you have to intervene in certain with certain steps. Now, this patient has got anterolateral rib fracture. So, what comes to your mind immediately? What sort of blocks comes to your mind?
So for anterolateral rib fracture, the most specific is the serratus anterior plane block.
Yes.
Sir, we can do other blocks also, but it will be more site-specific block for the anterolateral rib fracture.
Mm-hmm.
So the other option,
what are the other options? Yes.
so the other options from central to periphery are the thoracic epidural analgesia, then thoracic paravertebral block, then intercostal block, and the serratus anterior plane block. And also there are the paraspinal blocks, which are retrolaminar block, and the mid transverse process block, and the rectus spiny plane block.
So the paraspinal blocks we can forget for a brief period of time, because they are, you said that these are now site specific. So where would you give the paraspinal blocks, in which type of fractures?
Sir, for posterior rib fracture, I would prefer the paraspinal blocks.
Mm-hmm.
In this patient, I have an anterolateral rib fracture, so I'll go with the serratus anterior plane block.
So just for theoretical sake, what would be the indications and contraindications for thoracic epidural and the paravertebral blocks?
So the contraindications for the thoracic epidural is for the absolute contraindications and the relative contraindications. In absolute, there is a patient refusal, spinal cord injury, then coagulopathy, sepsis, and in relative contraindication, if patient is unable to sit, so the position problem, then anticoagulation. If patient is having any hemodynamic instability like hypovolemia, hypotension, then this is the contraindication from the thoracic epidural, but epidural analgesia. But if patient is having a bilateral multiple rib fracture, then thoracic epidural analgesia would be the choice. And also, this is the technically challenging to put the thoracic epidural. So that is also the one.
So I agree to all these things. One important thing to keep in mind is that whenever there is a polytrauma and involvement of spinal cord, and the spine surgeon wants to monitor the spinal cord, in this case probably a thoracic epidural would be a contraindication. That is one more thing. So what are the contraindications for paravertebral blocks or indications for paravertebral?
Sir, for paravertical block, we have to make seat the patient supine. Then again, this is the position problem. Also, there may be the vertebral fractures, transverse process fractures, in which the paravertebral block is contraindicated. And also the anticoagulated patient, we should avoid this block. But in comparison with the thoracic epidural, we can put paravertebral in anticoagulated patients. So it is in comparison with the epidural analgesia, it is safer, but it is also a relative contraindication for the paravertebral block.
So, literature now says that anticoagulation and coagulopathic patients would be a contraindications for thoracic epidural. That is fine. Paravertebral blocks, I still guess it's a contraindication in this kind of patients, and more superficial blocks would be indication.
Yes.
Now, this patient has got the 3 to 6 rib fractures. In the past, we used to give this kind of paravertebral blocks. So when you inject at one particular point, so what point you would inject in this case, Dr. Pooja?
So the point is in the paravertebral space, which is lined by anterolaterally by the pleura, posteriorly.
I'm asking you the point. Now, this patient has got from 3rd to 6th rib fractures. So, at
Okay.
what level
Okay,
you would
yes,
be
sir.
giving this?
So at the mid fracture level, I will prefer. So I'll prefer at 5 between. So patient is having rib 3rd to 6th fracture. So I will prefer it in the 4th to 5th.
4th to 5th. Okay. And do you and what volume you would inject in this case?
Sir, if there is a multiple injection, then I prefer 4 to 5 ml per.
You said that
per level.
you said only single injection. So, what volume you would be injecting?
Sir, for single injection, 20 to 25 ml, we can 15 to 25 ml we can inject.
And what would be the extension of the spread in this case?
So the paravertebral spread can be epidural. It can spread to epidural space. It can spread laterally also, and the spread can go to the towards sympathetic chain also. So this is the possible.
And how much sensory dermatomes would be affected with one single injection?
Sir, 2 segments above and 2 segments below.
Yeah, so around 4 to 5 segments can be affected with this, and you rightly said that it will affect the motor sensory as well as sympathetic. In
Yes,
fact,
sir.
if you look into the somatosensory evoked potentials with paravertebral block, they are more intense than the thoracic epidural, and they last more longer. This is the reason why the paravertebral blocks, they score more over the thoracic epidurals. And we used to give a lot of these. With landmark guided, where you hit the costotransverse junction, and then you just go around 1 centimeters beyond that, and you inject the local anesthetic. Yeah. So can you show the costotransverse junction? Somewhere at that point would be the costotransverse junction, and just beyond that 1 centimeters would be the into the paravertebral space. Now, you have also rightly said that but that it goes into the epidural space as well. Epidural diffusion is quite common. Around 70% of the times it goes into the epidural space. It can also go into the intercostal space, and it affects at multiple levels, and it can also affect the sympathetic ganglia. Now, one of the mode you said is the intercostal nerve. Why the intercostal nerve is not much practiced nowadays?
Sir, for intercostal nerve, it is for short duration, and we have to multiple injections required for the intercostal nerve block. So by this, we increasing the chances of pneumothorax. So we have a more specific blocks now. So we are using.
So you said that multiple punctures need to be done at the intercostal level. Where exactly the nerve lies?
Sir, the nerve lies inferior border in the groove, inferiorly to the rib, along with the intercostal vessels. Between the course of the nerve is between the innermost intercostal muscle and the internal intercostal muscle. So it lies in between these 2 muscles below the rib, inferior border of the rib.
Okay. Now, finally, we coming to the SAP block, the serratus anterior plane block. Now, can you just elaborate how do you do it, in what position you do, what would be the sort of ergonomics, and in case if you have got bilateral rib fractures, would you go for bilateral SAP blocks, Would you do a single shot block or would you go for catheter techniques? So all these things, can you just elaborate?
Yes. So we have done one bilateral SAP catheter. So I have a slide for it. So may I show the slide also?
Yes. Now let us see let us see what exactly you mean by serratus anterior plane block.
So, sir, the ergonomics for the serratus anterior plane block, the performer at the head end, the arm is abducted, and we use the high frequency linear probe, which is 6 to 13 megahertz. So, place the probe in the sagittal orientation in the mid clavicle line and identify the
Mid
second.
clavicular or mid axillary?
Sir, scanning to identify the ribs, I place the probe in the mid clavicle.
Mid clavicular. Okay.
Then I'll identify the second rib below the clavicle, and as we go distal, I'll identify third and fourth rib, and I'll go more caudally and laterally towards the mid axillary and the posterior axillary line. So
Yes.
at the mid axillary line, I will see the serratus anterior muscle only. At the anteriorly chest, we can found the pectoralis. We can see the pectoralis major, minor. Then at the mid axillary line, we'll able to see the serratus anterior, and as we go in the posterior axillary line, we can able to see the latissimus dorsi and the serratus anterior muscle. So the plane between is the plane between, we have to inject the drug, the plane between the latissimus dorsi and the serratus anterior muscle. So this is the ergonomics. I forgot to tell about the machine. Machine should be on the ipsilateral side.
So would you do it in supine position or in sitting position?
So we have performed this in supine position. So it is also the advantage of serratus anterior plane block that it can be performed in supine position in comparison with the other blocks.
Okay. Now whatever I have shown is, this schematic diagram is the plane between the latissimus dorsi and the serratus. Can we go between the serratus and intercostal?
Yes, sir. There is a two serratus anterior in the recent literature. There are two superficial serratus anterior plane block and the deep serratus anterior plane block. So the recent Delphi consensus also, there is a strong consensus for the deep serratus anterior plane block. So we can inject between
Consensus, you said. What was the consensus name?
Delphi consensus.
Okay, Delphi consensus. Okay.
So, according to that, we can inject the drug between the serratus anterior and the between the rib and the serratus anterior muscle.
So what would be the difference between these two techniques? What would be the difference in the sense clinical outcomes regarding the pain scores?
So there are so many studies which are comparing the deep and the superficial. So the patient, some studies have shown that, sir, it is a controversial topic. There is studies have shown that the patient outcome is better with deep serratus anterior plane block.
Okay. This is fine. So can you show
But
the? Yeah, tell me.
But also, sir, there are some cadaveric study which are comparing the deep and the superficial serratus anterior plane block. That is, there is one study by Abhijit Biswas et al. They compared that superficial and deep serratus anterior plane. They injected the 20 ml drug at the level of the third deep and the third, fourth, and fifth rib, and they found that there is no difference in the patient outcome.
But you said that it's a cadaveric study. That is not going to give rise to any
Yes,
clinical outcome. So you have to remember what you are saying exactly. Whenever you say a cadaveric study, there won't be any clinical outcomes. There will be outcomes related to anatomic the diffusion and its affection on the nerves. So what nerves would be affected in the deep and what nerves would be affected in the superficial?
So in the deep, the lateral cutaneous nerves will be blocked.
Yes.
And in the superficial, the lateral cutaneous from T2 to T9, the long thoracic nerve, the thoraco-dorsal nerve, and the intercostal nerve will be blocked. And yes, sir. And also in the deep serratus anterior plane block, the drug can percolate through the fracture segment of the rib also. So the fast we can get the faster onset of the block.
Okay, so in my opinion, since I do a lot of the deep serratus anterior, and we also keep catheters in the serratus anterior plane, I think it is more useful than the superficial blocks because it blocks the the nerves early in its origin before it divides into the anterior and the posterior branches. So
Yeah.
I think the deep would be more better than the superficial ones. Though I agree that there are a lot of controversies regarding this. Now, can you show that? Can you show that how the catheters are placed and what exactly would be the serratus anterior plane block?
Yes, sir. These are we have done put the two catheters for the bilateral.
Can you remove that?
multiple-
Can you remove that laser pointer and then
Yes, sir.
click so that it would be more better?
Yes, sir.
Laser pointer. Get it on the laser pointer.
So, yeah. So you want laser pointer or
No,
you-
no, I don't want the laser pointer.
Okay, okay.
No, no, get it on the laser pointer and click it.
Okay. Yes.
Uh,
So
Okay.
this is the case we have done in our ICU intensive care unit where bilateral multiple reef fracture was there from 3rd to 6th, and we put the serratus anterior plane catheters bilaterally. So this is the slides which are showing images showing bilateral catheters. So here,
yeah, okay, that's a video.
so we check the after the catheter placement with the 2 hours needle, we keep the catheter 2 to 3 centimeter beyond the needle tip, and we checked. We gave the bolus, and then we checked before bolus. We checked whether the catheter is in place or not under the ultrasound guidance, and then we fix the catheters bilaterally.
So now how much bolus you would give bilateral bolus and what concentration you use and what drug you use?
Sir, this is a bilateral catheter placement, we use 0.1% ropivacaine, and we use the bilateral elastomeric pump, and for that we give 8 ml per hour. So bilaterally, it will be 16 ml per hour. So the patient, so we are giving 60 milligram per hour to the patient, ropivacaine.
So you mean to say that when you do this, you give a bolus of 30 ml on each side, that is 60 ml, that is 0.1%.
Sir, in this
ropivacaine.
patient, sir, that was about my patient which is having a unilateral reef fracture 3rd to 6th. Now this is bilateral catheter, so we can reduce the dose. We can reduce the volume, and also the concentration is 0.1 here.
Okay, so now somebody asked about the combination of superficial and deep. That's not necessary. If you go for the deep blocks, that is more than enough. You introduce the catheters. Prior to that, with the needle, you inject local anesthetic on both the sides, 0.1 ropivacaine. I inject around 20 to 30 ml based on how many would be the rib fractures. For 3rd to 6th rib fracture, the needle position would be at 4th, and when you start injecting, you can see both a cephalad and caudal spread on both the sides. And then you keep the catheters and you can start infusion maybe around 2 to 3 hours later, 0.1% ropivacaine at 6 ml per hour, and then you can increase if it's necessary. Now, once you do that, you always see that with the spontaneous respiratory movements, the spread increases, it diffuses, the drug diffuses sort of cephalad and caudal. Even with erectospinal plane, we have seen that if you give at a high thoracic level and the drug descends, by end of the day, the drug would descend down into the sacral erectospinal. So how much catheter would be inside? So Pooja said that it would be around 3 to 4 centimeters. I use the multi-hole catheter, and this would be around 4 to 5 centimeters inside the any plane, and not beyond that. Recently, one of the companies have given us a multi-hole catheter, and it's a beautiful catheter with almost 15 holes, and we're going to use that. So how much bolus on each side? It would be around 20 to 30 ml bolus. It is all based on how much would be the fracture segments. If it is around 3 segments, I would use 20 ml, and it spreads adequately. If it's more than that, 4 to 6, then it would be around 30 to 40 ml. But that would be unilateral, as Pooja rightly said. So Rupinder asks which would be the company. We are supposed to be not to reveal this because it's still in its early stages. and they want to market this eventually. We are doing some CT scan studies with injections of contrast, and we're trying to see the spread, how the drug ejects out through all these holes, and whether the spread is very much adequate. Now, coming to the mechanism of action, just two questions. Is that okay, Amit? Because we need to do that. The mechanism of action of the SAB block.
So we inject the mechanism of action. So we give this block according to the osteoderm, dermatome, and myotome of the patient. The mechanism is we are using this SAB block. Drug is injected between the serratus anterior and latissimus dorsi. So the drug spread towards the blocking the lateral cutaneous branches from T2 to T9, and the drug also spreads towards the anterior side. So it is blocking other nerves also, long thoracic nerve, thoracodorsal nerve, and lateral cutaneous.
Any other mechanism of action apart from this?
Sir, there is with the chest wall movement, the drug also it affects the spread of the drug. And
Any other mechanism? So the local anesthetic is the serratus anterior is soaked with the local anesthetic, and then it tries to squeeze this local anesthetic during the respiratory movements. And anything else?
there are also diffusion and bulk flow.
Yeah, that is correct. That is fine. But
Yes.
the one more important thing that you had said a few days back in this particular patient, through
Sir,
fracture
sir,
segment.
Yes, sir. Through the fracture segment, drug percolates inside and it acts on the pleura.
Yes, it acts on the
Yes.
periosteum as
Yes,
well
periosteum.
as well as the intraosseous. So what we usually do in our practice is that we try to visualize the fracture segments with the help of ultrasound, whether they're anterior or they are on the lateral, where exactly the sites are close to the fracture sites. With the help of ultrasound, we try to place the catheters close to the fracture site so that it becomes more relevant. And regarding the last thing about the plasma levels, about the bilateral catheters, do you feel that we are going close to the toxic levels, Pooja?
Sir, we are calculating the maximum allowable local anesthetic dose, which is for ropivacaine is 3 milligram per kg, and we
Yes.
are diluting it 0.2 to 0.1%. So according to the calculation, we are not crossing the plasma levels.
And how would you assess that your catheters are working, or the block is working? That's very important to understand.
Sir, with if our catheter is working, the patient will able to breathe at rest. This patient is having difficulty in breathing at rest also, and while coughing also. So the patient clinical outcome will improve. The tachypnea will, the patient is having tachypnea. So if we have adequate block, the patient will have no pain, less pain or no pain. The pain scores will be lesser. Then the patient will be comfortable. Breathing will be comfortable.
Yeah, and what about the spirometric tests? Would you do that spirometric or
Yes,
incentive
sir.
spirometry?
Yes, sir. It is improvement will be seen on the spirometry also.
Yes, and you will also ask the physiotherapy to conduct some exercises so that the patient can breathe effectively. The lung volumes will increase, and as well as he would be more comfortable in the supine as well as in sitting position.
Yes, sir.
So, anything else remaining to discuss? Have you got any other slides to show?
Yes, sir. So these are the blocks preferred for the particular fracture site. For the anterior, the choice can be serratus anterior plane block. This is given by the Willem et al. In 2020. So for anterior, serratus anterior plane block. For posterior and lateral rib fracture, erector spinae plane block, serratus anterior plane block, and paravertebral or epidural. And for the bilateral fracture, thoracic epidural or bilateral paravertebral blocks, or bilateral erector spinae plane block, or bilateral serratus anterior plane block. So also,
I think each one of us should read this. These are two articles. One is by May and one is by Williams. And these are really good articles. They give a proper algorithm and how the central neuraxial and paravertebral blocks have been replaced by these these interfacial plane blocks. That's very good to understand. You can have your modifications done. There were two questions. One was the question did not understand. I just forgot that. There was one question which had come before. I think Shiva had asked about the local anesthetic infusion, and there was one more question. So if you can just have those questions. For how many days the catheter can be kept? So in our institute, it's a protocol to keep the catheter for 48 hours. But if it deemed necessary, we can extend the catheter with all aseptic precautions. We can refill it because it's a closed loop. Until you refill that, it becomes open. So you have to take all aseptic precautions. Now, what is the maximum dose for infusion? So they are given a guidance of around 8 to 16 ml per hour, but we don't go that high. We just have to be around 8 ml per hour, and then along with multimodal analysis, this can be effectively done. I think Pooja, we are done. Our time is up.
Yes, sir. Thank you, sir.
Thank you, Pooja, and thanks, Amit. Thanks, Hetal, and thanks, BOS. Thanks, Dr. Shiva. Thanks a lot.
Yeah, thank you. Thank you, Divan sir. I think this was a very useful academic discussion, and